अधिनायक जय हे भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा, विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा। तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाए तव जय गाथा। जन गण मंगलदायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे।
Members who have registered for today's scientific event. Now, in the history of IDA, Surat branch, since around 50 years, hardly any event has taken place on a weekday. Today it is something different, but yet we have almost 65 registrations. This shows the zeal to learn and to learn new things, new concepts, and from the master clinician, Dr. Leiser from Israel. I once again I thank you all on behalf of the team IDA. Thank you for making to this event and have a great day of learning. Thank you so much.
I would like to ask our President, Dr. Jigar Vakil, to honor the speaker. Dr. Leiser, please give a huge round of applause. Nothing is possible without the support of our sponsors. So I would like to ask our sponsors AB Dental and Blue Dent and their representative representative Chanchal Zawar and Raghav Maheshwari to please come forward. I ask Dr. Pinak Bhai and Dr. Ruchir Bhai to kindly felicitate them.
Thank you everyone for joining us for this lecture, and it was really amazing to see that on a weekday we can get a participation of 50 plus dentists. So it really means a lot, and once again thanks a lot, and I assume that you will have a lot of learning and takeaways from the lecture of Dr. Leiser. Thank you so much.
First of all, I would like to thank our today's sponsors, Blue Dent and AB Implants, our co-sponsors, Patel Dental. I would also like to thank our today's guest speaker, Dr. Leiser, who came all the way from Israel to share his knowledge with us. I would also like to thank our President, Dr. Jigar Vakil, our Scientific Chairman, Dr. Parcha. I would also like to thank our Coordinator, Dr. Pinak Kapadia. And last but not the least, all of you people who gathered here. So without not much wasting much of your time, I give the mic to our speaker.
So before we start the proceedings, I was asked to give some introduction to our coordinator also, Dr. Pinak. But frankly speaking, we don't want to waste much of our time in that, and in Surat he is very well known and he actually doesn't need any introduction. So I would like to welcome Dr. Pinak to introduce our speaker for the today here, and sir, the stage is all yours.
Getting to hear an international speaker in Surat is as unlikely and is as big a privilege as getting to watch an international cricket match in Surat. It is that rare an event that we don't have to, whenever we want to go to listen to a speaker, we don't have to look up train tickets or flight tickets, and we just have to get up, change our clothes and reach the venue. It is a big pleasure and a big opportunity for all of us to learn. I have been tasked to give the introduction of Dr. Yoav Leiser. He's DMD, MD, PhD, and he's a specialist in maxillofacial surgery. He was asking whether there are any maxillofacial surgeons in the audience. I see Grugesh is Uday here. So, Dr. Leiser received his DMD degree from the Faculty of Dental Medicine at the Hebrew University in Jerusalem, Israel in 2004 and completed his PhD on the subject of gene expression and hypoxic signaling pathways in 2005. He finished his MD studies in 2018 at the Faculty of Medicine of the Tel Aviv University, Israel. In 2009, Dr. Leiser received the Itay Sharon Rambam Atidim Grant and completed his postdoctoral fellowship at the Cancer and Vascular Research Laboratory headed by Professor Israel Wlodowski at the Technician in Haifa, Israel. In 2011, he was one of the researchers to receive the prestigious Wolf Foundation Award for Outstanding Postdoctoral Studies. Dr. Leiser is an attending surgeon in the Department of Oral and Maxillofacial Surgery at the Rambam Medical Center in Haifa, Israel. He is the head of the laboratory for oral cancer research and previously served as supervisor to MSc students in basic science research and MD thesis. Today, Dr. Leiser specializes in surgical oncology and surgical and dental rehabilitation in the maxillofacial region using AB Dental SPI technology. Dr. Leiser has served as the lead editor for international peer-reviewed journals and has published more than 30 scientific and clinical papers. He has served as chairman and lecturer at several international and national conferences on basic sciences as well as professional maxillofacial surgery and oncology conferences. In 2014, Dr. Leiser was elected treasurer of the Israeli Society of Oral and Maxillofacial Surgery and today serves as his secretary. This was the CV given to me, but when we were Googling, I realized that Dr. Leiser is a fantastic artist too. He has his own website where he has put wood sculptures, glass sculptures, paintings, and he himself has written that I have always loved art and have been sculpting since the age 12. Thereof, three-dimensional printers allows us to combine medicine and art and print missing parts of facial bones and re-sculpt them. For me, it is a tremendous feeling of satisfaction. So, you know, when we were in college and school, the people who were best with their hands and who were the best artists turned out to be the best dentists. And plus he is PhD, so he will have a very strong brain also. And we are doing a topic that is cutting edge topic of immediate loading and advanced protocols in all kinds of bone conditions. So please feel free to involve yourself fully. Doctor will tell us how he wants to do the question answer sessions, but we assure you that we will give you a good evening. Thank you.
It was amazing, thank you. The first time somebody made Google on me. You will have to bear with me because I made one mistake the first time. I made a steam bath before going here and I'm sweating until my temperature evens out. I'm not, it will take time, so sorry. It's not working? So how many people here, by raising hands, are doing implants? Great. How many are doing total jaw? How many doing immediate loading? Okay. And any one of you heard about things like patient-specific implants or 3D printed implants? Okay, 5, 7. Great. So this lecture is going to be to all groups, to all cases and to all of you. Some of you will take the things from the beginning of the lecture, which is more theoretical, as possible. And I want you to laugh because we're going to start after the technical issues, and I want you to laugh because I'm trying to break the ice so we can be like friends and not me speaking as somebody who comes from another country. Okay, so I hope you will all. So he started gathering it in a nice white box with the ribbon and everything. He put it on a wheelbarrow, the white wheelbarrow, and he was hauling it out of the factory. And when every night he would take the wheelbarrow put the box inside it with a lot of sawdust, and then every night the factory guard checked through the sawdust and was looking for something. He didn't know what he was looking, but he said, something must be wrong, he's stealing something. And he never found anything. After 5 years, the guard was retired. He pulled the worker aside and said, look man, I know you've been stealing something. I couldn't find it from all the sawdust that you showed me. But for the past 5 years, it's driving me crazy. So I'm retiring now. Please, I swear, I will never tell anyone. I just need to know, just what the hell have you been stealing? So the guy says, do you really want to know? I said, yes. Will girls. Love. Okay. Very nice. So, why am I showing you this? I'm showing you this because sometimes from all the trees you cannot see the forest, your focus is on the wrong thing. And I will try, the aim of my lecture is to educate you on immediate loading, the procedure itself, step-by-step explanation and rationale, what are the basic surgical skills that are needed in order for you to achieve full jaw rehabilitation and immediate loading, understanding when it is needed to use patient-specific implants as well, and the possible complications and solutions. My aim, I don't think, so I have enough. So my aim is to give you a protocol that you never say never. I want to show you the forest amongst the trees. So the protocol means that the patient comes to your clinic, sometimes, today, you say, I'm sorry, I cannot reconstruct you, you have 0.5 bone or 2 millimeter bone, this is too little for implants, so I need you to go to a maxillofacial surgeon or go to the hospital and they take bone from your iliac crest and they reconstruct you, okay? That's something that can happen, I believe it happens to one of you at least. So what I'm trying to show you that with this protocol, you'll never say never. I'm going to show you and I'm going to prove it to you. So if you have a patient that comes to the clinic and has between 10 to 13 millimeters of implant, that's bone level. So in this case, you can use screw-shaped implants, normal implants that you're using all the time. Sometimes the patient comes and he has less. He has between 5 and 10 millimeters. So in this case, you can use specialized implants. In Israel, there was a good company. It's looking so bad. Okay. So in Israel, there was a company called Pyramidion. It's a company that made implants that look like a pyramid. So it goes inside the bone and it opens up. And what happens is it increases the bone to implant contact. I will talk about it later on. But also other companies produce the same, short implants, 7 millimeters, 8 millimeters, and you can immediately load them, but you need to know how and how many implants. And you have to know the thing that is most important is that everything is related to the contact of the implant with the bone. As much as possible if you want to immediately load the full jaw. And sometimes the patient arrives and he has a 0 millimeters or 5 maximum. So in these cases you can do these type of implants. These are 3D printed ones and they are specifically for one patient. It's not something you can take from the shelf, but it's something specifically for one patient that you do on a 3D CT. So 3 options, and with these options I'm going to go each one and I'm going to show you what the things that you need in order to learn how to use this protocol, and you will never say never to your patients, I hope. So the overview is to first talk about the patient-specific implants. What are they? Where were they first used in oral and maxillofacial surgery? From the oral and maxillofacial surgery world, I'm going to talk about dental arena, and I'm going to talk a little bit about what affected me and the way I was doing everything, and how I used to do it in maxillofacial, and then I started doing it on dental. And then I'm going to talk a little bit about the protocol for immediate loading, and then a little bit of history. I'm sorry, history is important. And then immediate loading dental implants with all the types, and then immediate loading of patient-specific implants. And I'm telling you for sure, when you finish this lecture, you're going to be masters of information at least. Then you're going to have to start doing that, but at least the knowledge will be. So let's start. First of all, what is a PSI, a patient-specific implant? This is a one-of-a-kind artificial or biological implant that repairs or replaces a bone or a tissue part in a living individual. There are many materials out there that can be 3D printed. From PEEK is polyethyl ether ketone, and also plastic and even cement. You know that you can also print the houses. The future is there. So the medical change really happened when we were able to start printing 3D titanium. These are the three materials that I'm using. In most cases, it's related to the modulus of elasticity. Did you hear that once upon a time when you were studying? Modulus of elasticity is the pressure that you put on something until it breaks. So there is like a graph, it doesn't matter. But the modulus of elasticity of the first material from the left, the gray, I'm sorry, the laser doesn't work on this type of... So on the left side you have the PEEK, which is the polyethyl ether ketone. This material has the same modulus of elasticity as bone. So it's around 120. So in this case, you can use it for, not for load bearing, but for substitution of parts of the orbital, part of the nose, part of the zygoma, whatever you want. There are another material, the second one, is the titanium, which in this case you have modulus of elasticity of 230, so it's much, much more stronger than bone. It will not break, but the bone will. In these cases, you can use it for load bearing, which means you can load it and use it for either dentistry, or if you don't have a jaw completely, or zygoma, or full something that moves, or something that needs pressure, this is a good option. And also, I think, also in here, you are starting to do aesthetics. So this, the third material is porous polyethylene, and it's like, it's a very soft material. You can manipulate it, and you can even use it for chins, for angles of mandibles, and for everything that you want, which are things that are for aesthetic reasons, and not for load bearing or load sharing. So these are the two materials, but I will focus my lecture mainly on titanium, especially for dentistry. So history, a little bit of history, one-on-one. At the beginning, we found iron. Iron was found in Mesopotamia, 3000 BC, before Christ. We started using it by melting it and using it, and it was a very good material. And then, I don't know, I think it was a mistake like everything else. There was a mistake, and a little bit of carbon entered the iron during the procedure, and they created steel. Steel was much better. Steel was much stronger, and it was, but the problem, it was heavier. So, steel was heavy, and not biocompatible, but it was much stronger. They use it in Japan for the knives and everything, for the swords, sorry. And then, around 1791, this guy on the left, yes. William Gregor, he actually the one that found titanium, but he did not coin the name. So the name was coined by Klaproth, because the titans of the Greek mythology. And this material is amazing because it is as strong as steel, but half as the heavy. So it's very, very light and very, very strong. And it's actually kind of been born to be 3D printed. So it's basically a 3D printed material. So the 3D printed implants were used originally in maxillofacial trauma by me. So I started by trying to reconstruct parts of the skeleton of the face. And the need for 3D printed of dental implants, especially in severe atrophies, in cases when you have 0 millimeters of bone, this was the catalyst for me. So I started thinking about, okay, we have to do it in dentistry as well. So using laser printers, we can now reconstruct severe atrophic jaws and even immediately load them. So I will start by giving you a couple of examples, but the real examples will be on the second part of this lecture. So example for maxillofacial world. This is something that if you're not a maxillofacial, it's just for fun. Okay, so sit back and enjoy. That had a zygomatic fracture. She had a zygomatic fracture, looks like this. Okay? And in this case, she was treated in a hospital in Israel, and it wasn't so good, because the zygoma is also part of the orbita, the flow of the orbita. And the eye, when it was hit, you can see what happens on the left. The sinus, the maxillary sinus breaks, which is also the flow of the orbita. Money, if you're counting money, that would be a great deal. But for other purposes, it's not the best option. So this is the way the patient arrives to my clinic in Rambam Medical Center. So in this situation, she was treated already, and they took bone from her hip, from the iliac crest, and they put extra bone. And what happened is the eye went upwards. I'm not going to talk to you that much about maxillofacial, it's not the topic of the case, but you can see on the left that the eye is a little bit on the top. It's not the right place. And if you look closely, you can see that it's different levels of in the field, in the playing field. So what we did is we received new technology, which was the 3D printing, and we said, okay, computer, you have the right eye, which is the normal eye. So take the right eye, mirror it to the left eye, and tell me what's the difference. And this is what we did. So the right eye was mirrored to the left eye, and he told me that this part, the blue turquoise part, is the difference. So now I can print. So I said, okay, let's print this in PEEK, and I will put it inside the orbit. I'll take everything out, and I'll put everything back. So this will be anatomical. And this is what we did. This is the orbita of this patient. The cut is very, very, very conservative, even though it looks very bad, but it's very conservative. And then we put it inside and put the 2 screws, and that's it. And so the patient, after 6 months, didn't have any diplopia. It's not a 100% case, because you have a lot of changes. You're looking at anatomy from the skeletal point of view, but a lot of surgeries already been made. But still, no diplopia, and she was very happy. And this was the first case that I did. And then this guy came. He was a soldier in the Israeli army, and he was very fond of fighting. He was hit by a guy. When you have fighting and somebody hits you, usually when you break the zygoma, which zygoma usually breaks, do you know? The right, the left? The left. Most of the people are right-handed. In this case, it was actually the other side. But anyway, again, he was, somebody did the first operation in another hospital, and he came to me. The first surgery, I did not know what to do, because we didn't have 3D printing yet, so we did what we can. So what we did is we take bone from the head, from the calvaria, and we try to put it inside the orbita and move the orbit forward, so it will be at the right place. And also we put some bone on the top of the zygoma, so it will be like a normal zygoma, a zygomatic malar point. But you can see the result. That's a very bad result. It's not good. It's not. We are, until the age of 3D printing, we were artists. So even though, as the guy that told about me, I am an artist, but in this situation, it's a very bad artistic result, because the patient is lying back during the operation. You don't really see anything, and you prefer not to be an artist, but to be a surgeon, and very precise one. So this is what we did. Again, the same thing. You can see how much the orbit, the right orbit, is bigger than the left one. So this causes all the problems. So what we did here, again, we took the normal orbit, the left one, and we mirror it to the right one, and you see how much the difference is. So you can't do it with 1 implant. So we used 2 implants to reconstruct everything. This is the operation itself. And this is the patient after 1 week. And this is the patient after a couple of months. You can see that the result was very good. He doesn't have any diplopia, he looks better, and he was very happy with the result. The scarring is very bad. I don't think we do it now anymore, but this was many years ago. So this guy, this guy, this is something I believe none of you know, because in the news you like to listen to only bad stuff about Israel. You don't really know that we are working as surgeons and we also treat everyone around us. So there is a war in Syria, which is a civil war, and people are getting hurt and they are left on the border. Israel picks them up, flies them to a hospital in Israel and treat them without pay, for free, because we are not going to leave somebody dead on the border of Israel. So this guy, I was on call, and this guy was, he said he was growing tomatoes, and he was hit by a shrapnel or some kind of a bullet in the jaw, and this caused all of his jaw to be completely lost. So the lower jaw was completely lost. So you have to understand, in this situation, I'm not going to treat him for 1 year and take fibula and try to make his whole jaw. So I need something fast, and 3D printing was a possibility. So we said, okay, we can do it very fast and create a new bone, a new jaw. What's the problem? We are the first in the world. Nobody ever done that. So what to do? How to do it? This is how he looks when he arrives to the emergency department. If you look closely, you will see a molar not in the right place. And after you clean him and everything, you can see the exit wound. You can see a very, very large exit wound, and the entrance wound, the bullet was around here. Very small, and this is the exit, a very big one. So in this situation, you have to think of, okay, what can I save? And when you do a 3D CT, you cannot save anything. You don't have a mandible. The mandible is lost. So, and the molar, you can see it over there. The molar is also lost. If any endodontist want to treat it, it's okay, but it won't survive. So I'm a dentist as well. So I'm starting to think, maybe I can do what I can. So the first operation, I don't do anything. I just open up as wide as I can. I do tracheostomy so he can breathe. And then I connect part of the whatever is left to the other part, so it will be more or less equal. And then I start thinking, okay, let's take from another patient that I have a lot of patients. I will take a jaw that almost looks like the upper jaw that he has, and the angle of the jaw I can copy, and I will do a 3D printing device. So this is what we did, and we took this part, and I said, okay, so leave me like a cradle so blood vessels can go in, then it won't be completely closed. And then we will put bone here from the iliac crest, and then after that, I was sleeping and I wake up and I said, oh God, what about the muscles? Everything needs to connect, so I need masseter, temporalis, masseter, medial pterygoid, everything should connect. So I started to tell them to open up areas, to make me places where the bone can be exposed so the muscles can connect. And you can see how much before the age of 3D printing, this is artistic, this is surgery, real surgery. This I did by hand, and this was printed. This looks like a mandible, okay? And this is the surgery. I don't know if you can see anything.
Perfect.
Yeah. Okay, so this is the surgery, and you can see that this is the anterobellis of the digastric muscle connected to the mandible, and then we took some bone from his hip, and we put it around the area, and then we added some bioguide and bio-os. This is dentistry, and then we close up everything. This is the picture of the AP, the anteroposterior Röntgen. And this is the patient after 2 months. He had a functional jaw. He can open, close, and speak, and everything. And it was alive, and now we can do dental implants. The problem is that he never came back. I don't know what happened to him, but it was the first in the world. So the BBC came, and if you want to see me 10 years ago, I'm much younger. I don't know if it works. Oh, I don't know if it works, but anyways, there was a story about the situation. Let's see if it works. No. Why isn't it working? I don't know. Anyway, you can see it in the Google. So this guy, also something very interesting, he was playing a game that you hold a firecracker inside your mouth. And the firecracker, of course, exploded, and he lost his left eye. This is a glass eye, and it plunged into the orbit, the sinus, sorry. So again, what can we do? We can use 3D printing and reconstruct from the corrected eye to the bad eye. And this is how it looks after the surgery. And he didn't change his glass eye, so we cannot give you the final result because I don't know what happened to him, but it was good looking now. So this guy was a motorcycle accident. He had a motorcycle accident. This is a panfacial trauma, something that you don't really see a lot, but I think maybe in India you can. I've seen many people drive without helmets, and I think this can happen. So that means that all of the face is broken into many small pieces, and it was reconstructed in a hospital in Israel, but it wasn't so good. You can see here, I don't know if you can see, but the zygoma is crooked, it's not in the right place. So I'm not showing you in order for you to learn how to do it, but I wanted to show you how it looks. So this guy is the post-trauma guy. So this guy came to me like this, and I asked him, how did you look before? So I was looking like this. So he was a very good-looking guy. And this guy is a different person, but it's the same one, only after the accident and after the treatment. So the treatment wasn't so good. You see that the face is widened, the eyes, both of them are back. So in this situation, I cannot take one eye and do mirroring to the left eye. It's impossible. So what can I do? Again, I'm running into problems that, like a pioneer problems. So what I did is I said, okay, so we take the not so bad eye and we fix it on the computer, and then we do the mirroring on the left eye. And this is what we did. And also we fixed the nose with the same material. It's called PEEK. It's a plastic. Because it's not load bearing, you can use it. And this is the patient, as you saw, this is the patient when he arrives at the clinic. This is the way he wanted to look, and this is the final result, which is good. It looks okay, but it's not 100%. Again, it's impossible in medicine. And the last, but not least, this woman, because it's a different material, I wanted to show. It's a sex change surgery that went wrong in Thailand. They destroyed all the mandibular angles and chin, and the planning was to make a new chin and new mandibular angles. You can see that the patient has like a turkey neck. So he doesn't have an angles. That means that you can see the area here, and it doesn't look so good. And she said, I want you to give me a new one. So this is the material. It's like playing with potty. It's very easy. You can manipulate it and cut it. And it comes also with custom and also with over the shelf. So you can have chin over the shelf, and you can manipulate it a little bit in the ER or in your clinic, or if you want somebody to have a nice zygoma as well. So this is the before, this is the after. So why did I show you all of this? Not to tell you that I'm a very good surgeon, no. That I'm taking you on a journey with me on the way I did everything. Maybe it will help you to aspire the same. So from the maxillofacial world, I said, okay, why not try to do everything I know already into dental? And do 3D printing in severe atrophies, in very severe cases. But I started slow, I started in small stuff. So first of all, what is the process of making this stuff? So the process is called selective laser sintering. This means that it's an additive manufacturing technology that uses a high power laser to sinter, I will explain later, small particles of polymer or titanium powder into a solid structure based on a 3D CT model. That means that you take a laser and you shoot it into a powder of titanium. And you can, the minute the laser hits the powder, it becomes titanium. And you can do it by pixel, 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 and create whatever you want 3D print. It's very easy, actually. The only problem is that it needs to be in an environment of 0 O2, so argon, and the process is slow but very, very, very accurate. And then after that you have to clean it in order to put it in a human being. I will show you the process, if it will work. I can see that nothing works today. And then he puts the powder back, and then you can see it. It's very nice. You can do whatever you want with this, and it's kind of fast, but it's slow. The lines are slow. So, but our imagination is our only limit in this situation. You can do things in space. You can do like parts of machines. You don't have to buy from UK. You can buy from yourself. You can do parts for anatomy, from whatever you want. That's the dream. You can do it. So this is the first case that I did. This is a patient 10 years ago, I think, 12 years ago. She needed to do a small 3D printed implant on the left side of the mandible, and also sinus lifting with PRF, PRP. I will show you later on this case because there was a complication here, and I want to show you how to treat it. So this is the patient. She's a woman, and she had very bad implants on the lower part of the jaw, but she didn't want to change them due to financial problems. So we left the left implant just for the time of reconstruction. After we finish the half a year, we will take the implant out. And this is the 3D printed implant, the planning. Today I'm doing it completely different, but this was many, many years ago. So this is the planning, this is the printing already, and this implant also has small projections that will go into the bone. I don't need that today, but it's nice to have. So you first expose the area, you have to do good vertical releases. Then in this situation you drill, and then you put the implant on top of the bone and connect it with screws. Yes, you can add bone. I'm not doing it either again, and close everything up. In the case of the maxilla, we did the sinus lifting in both sides. We used PRF, and I will talk to you and show you how to produce platelet-rich fibrin, PRF. So you will know the system by then. And this is the patient when she had the final restoration on the top. So this was one of the first cases that I did. And then I had some appetite, and I said, why not do a bigger one? So this was the second case. So in this situation, she has enough bone. So she has from here to here, that's a lot. But the problem is the nerve, it's very, very high. So it doesn't give a lot of bone here. And somebody did something that looks like this. I don't know what it is. It doesn't look like an implant, but it was supposed to be on the lateral side of the nerve, lateral to the nerve. But it was like sticking out, and it was painful for her. So the planning is to do 2 implants in the back, but to bypass the nerve. You see how you do it? How you plan it? So the planning is so accurate that this will be also the picture of the final restoration, the final surgery. So this is the nerve, and I'm going to bypass it with both sides. Oops, sorry. So the surgery. First of all, you expose the area. This is the nerve. You can bypass it. You have to see it. Then you put the bone. If you want to put bone on these type of implants, you need first to do drill holes. I don't know if you can see the holes from here. I don't see them, so I hope the resolution gets better. And then you close everything up, and you can use the implant. And you can see the 3D CT post. You can see that she didn't have any problems with the nerve. It was closed, but nothing. And this is after the planning, this is the execution. So it's more or less the same. That's the advantage of doing something with 3D. It's very, very precise. And she has a very stable result. So other options you can do, and especially in cases where the patient arrives and he wants teeth. He wants to have teeth immediately. So you can, in this case, the bone is so thin in most areas, and the good bone is around here, so you cannot do an implant here. But if you cut here, then the implant will be very, very unesthetic, something that I wouldn't do. So you can either create more bone by buccal augmentation, or you can do something like that, that you extract the two canines, and you use this type of device that goes into the hole that was made by the extraction. So the implant, again, will be, because it's titanium, it will integrate with the socket. So it's a very nice option. Another option, especially this option is for patients who want teeth now. You can do this, and then you can do sinus lifting, and the patient can have implants at the back, and you can immediately load this part, and she or he can have teeth immediately loaded. And I will show you a case. And another case also, the patient comes, he has teeth. He's walking around with this and says, I don't have a problem with my nerve, I don't know what you're saying. And I'm telling you, all your implants are gone. You have to do something else. And this is the other option again. In this situation, you want to save as many bone as possible. You can see the bone in the midline. I will use it for implant. I can use this type of implants to bypass the bone, or to save some bone in order to do implants, normal implants, and incorporate it together. So I will show you an example. So this case, this is a patient that came to me, and she said she wanted to do, she doesn't want to go out without teeth. She wanted teeth immediately. She had like a prosthesis, and you cannot do implants here. That's too short. It's too thin, it's too short. After, maybe if you cut, you'll have around 5 millimeters. You can do 5 millimeters short implants, but you need more than a few. But in this situation, the planning was different. So the planning is to do sinus lifting in both sides, and then to do it 3D printed, but again, there was good bone in the midline, so I could use that. So I decided to move one of these, take it out, and then to do an implant instead, and connect everything together. So she will go out from my clinic after 24 hours with teeth, and she can wait half a year to get the final restoration. So this is the surgery, this is the sinus lifting with the 3 implants at the back, this is the 3D printed implant, this is the implant that I did in the midline, that I saved some of the bone, this is the implant itself, and you can see on the left side the sinus lifting of the other side, and the implants as well. I didn't show you all of the surgery. And this is the patient when she arrives to the clinic. You can see her before, and 24 hours later. Just 24 hours. So this gives you a very solid and stable result, an aesthetic result. So the patient doesn't have to wait more than 24 hours. Another case. I'm showing you that because also this case gives you a video to see if it works, I don't know. So this is a 55-year-old healthy female. She came to the clinic for posterior maxillary reconstruction, and she didn't want teeth immediately, but she wanted a reconstruction. So the treatment plan was on the left side, left sinus area to extract and do implants with posterior maxillary closed sinus lifting and immediate implantation. And on the right side, due to chronic sinusitis, and she was also treated with something that is called Kaltveluk. Kaltveluk is a procedure to clean the sinus. After that, it's basically contraindicated for sinus lifting. So the only option for her is either nothing or 3D printed implant. So we planned on to do 3D printed implant, and I want to show you the surgical plan. So the surgical plan is on the right side to do a 3D printed implant, and on the left side, you have enough room that you can do normal implant on the left, the first one. And the second one, you need to extract the tooth and then do a short sinus augmentation, closed one, and an implant. Nothing that sophisticated. So this is the 3D plan. And cross your heart, I hope it will work. Yeah, without music. Okay, there is music. You don't have a volume here. Okay, I will speak. You want me to sing? No, I won't sing. I can speak though. Okay, the same plan as I showed you before, is just running slower, and it's 3D, so you can see the movement. So 2 implants, everything by hand. I don't do guides, but you can do if you want to, with guides as well. And this is the final produced product, and this is the surgery. The first thing, you expose the area. You have to know how to do the cuts, and then you lift both sides. This was done on live surgery with doctors. Most important, take out everything that is infected. That's very important. If you see that on a CT, you have to do it. Then the sinus, the closed sinus lifting. Then we add the bone. Bank some more, and then we do the implant. This is an I-55 of AB Dental, if you are asking. So this was the left side, and then the other implant on the front. First you mark the place where you want to do the implant. Then you can drill according to the CT. You can see how the implant is hydrophilic. It absorbs all the blood until it reaches the bone level. Then you close everything up. Now the most important part is to release the soft tissue. This is something that some people are confused about, but you have to release the periost if you want to close completely, hermetically. And then continues with the resorbable suture in this situation. Everything is closed, and then you go to the other side. The other side, the video is less informative, but you expose everything. You have to have a good vertical release in this situation because you have to expose everything much better. Then this is the 3D printed implant. It's a little bit areas in the sarcoma as well, so it goes all the way up. Then you can put the screws in the place. Both sides. This is the sarcoma. And after everything is very stable, you also do the porosity, the posterior part. And after everything is stable and you put everything together, you have to release the soft tissue because everything needs to be closed 100% waterproof. This is the final panoramic view. And you can see also 2 months later. This is the implant, and this is the implants that are not exposed yet. This is the 3D. I'm sorry that you couldn't hear the nice music, but you had me. So, we don't have. I wish every time they show me this, I said, no, nobody has that. Finished. So immediate loading, history and protocol. Is it possible to immediately load it to total jaw? You can know that it is, but it was actually coined and made and realized by Leonard Linkau over 60 years ago. So he was the guy that really contributed to the protocol that I'm doing today. As early as 63, he also developed an implant, the Endosus root form implant. Later on, the protocol that was ultimately adopted was to immediately load these implants with overdenture or acrylic, provisional fixed bridges. It was the beginning, so he had also some failures, but he was a pioneer in his in the field. So the immediate loading subperiosteal implants, so he took subperiosteal implants and also did immediate loading of them by drumming on the implant into the bone without screws in 64 already. And in 67, the Endosus blade implants. Have anyone saw a blade implant in his life? That's a very old implant, a very good one, but a very old one. He also immediately loaded these implants. And in 67, he carefully established a protocol for immediate loading in a root form procedures. And so on and so forth, and he placed it into immediate function as well. Charles English also explained us the things that I'm using today as well. So things that you need to know prosthodontical wise is to have narrow tables as much as possible, not more than 15% angulation inside. You have to have group function, which means that all the teeth needs to be connected if you want to do immediate loading, especially in the area, the posterior area. And another thing that is important, the histopathology showed by Professor Carl Donath that the average of 72% bone to implant or bone to metal contact was established when you do immediate loading after a couple of months. So that means that something happens when you do the implants and you connect them and let the patient start eating. And the thing that happens is the body reacts to that. So the body can react to micro movements and also to macro movements. This is the blade implants, if you ever saw. I tried to take one out, it's very hard. I will show you later on the thing that I was starting to say. So the immediate occlusal loading window, the formal is 14 days. So you're doing the implants, extraction implants, and then you have 2 weeks to do the teeth. What is the rationale? The rationale is micro movements are good, macro movements are bad. If you move a little bit, it will cause bone formation. If you eat slowly and small bites, dalbat, micro. If you want to eat malai kofta, then it's a macro movement. You need to eat strong food, so that's not good. The bone interface is stronger in the day of implantation placement compared with 3 months. So if any one of you have seen the graph, it starts and then it plunges around 2 months and then it starts going up later on. So the worst part is 2 months. So the bone is not quite as good as you think, even though you waited 3 months for the mandible, but it's still not 100%. So the role of floating is to cause lamellar bone formation and to avoid as much as possible woven. Woven is a bad bone, is the bone that creates like a cast when you have fractures that are moving, and it's a bad option. So the surgical procedure of the implant osteotomy preparation can also cause something that is called RAP, it's regional acceleratory phenomena, and this is something that we use a lot, especially if you're doing surgery. It causes some kind of change in the velocity of everything that is around the implant. So everything is starting to be created faster. When we're doing orthodontic surgery and we cut a maxilla, and then we give it to the orthodontist can do the movement of the teeth much faster. It can take him, I don't know, half a year instead of 1 year, because the regional acceleratory phenomena causes the bone to react to the fact that there is surgery going on. And this is very important. The bone to implant interface is the most at risk when we are talking about 3 to 6 or 3 to 8 weeks. So the first 8 weeks, the graph goes down. We are at weakest in 8 weeks. So we tell the patient we don't want him to eat anything, only soft food. It's like a prosthesis. Later on, it starts to grow, 4 months, 3 months, it's okay. But the first 2 weeks is very important. Don't eat anything. Even at 4 months, it's only 60% mineralized. So it's not 100% even after 4 months. The remodeling, during the remodeling, we want to create as much lamellar bone, but as few woven bone. I'll show you an example. This is lamellar bone. This is a very structural anatomy of a lamellar bone. It looks like wood. It has Haversian canals, etc. And this is the difference between this and the Swiss cheese. This is the woven bone. This is something that you don't want to create. And you can create if you're not doing it correctly. If you're eating fast enough, strong enough, you don't do everything by the book. Taking enough implants, connecting them, distancing them. I will try to explain everything. You have to be a little bit patient. So the rationale for us is to do immediate loading, not only to reduce the risk of fibrous tissue, but also to minimize woven bone formation and promote as much as possible lamellar bone maturation. It is not something new. So the concept of this is something that you probably understand and know from bone density. The Muay Thai fighters use repeated strikes on their fibulas, on the shins, in order to gradually harden their bones. There was research done on these legs, and they saw that the density of the bone in these patients, in these people, is so strong that it's almost like superhuman. And these people can even strike trees and take them down. But it's not something you can do at the beginning. If they come to the first day and they hit, they will break the leg. It's very weak. But with time, the bone is being created, more and more bone. There was a guy called, it's still, Mukao Po Pamuk. He would kick down trees, and if you've seen the movie with Van Damme, I think only the old people will remember, but he eventually broke the tree, and this is something that you can do gradually. Okay, risk management, also very important. So, as I told you up till now, I want to have as much contact with bone and metal, bone to implant contact, as possible. So in cases where I have short implants, I have to increase the surface area. So the only way I can do it is to increase the amount or the number of implants. That's one thing. So I will take 8 to 10 implants and split them if I want the maxilla, and 6 to 8 if I want the mandible, if I want to immediately load these implants. Also, the implant size is very important. Which is more, the length or the width? There's an answer already, so it's the width. Why? Because the width is also important for the stability and also for the resistance of the implant. For instance, if you have a patient-specific implant, it's much greater and much larger because it has more support and more screws that are connecting to the bone, so it has a bigger contact with the bone. So a 1 millimeter increase in the wide of the implant increases the surface area in 40%. So if you are planning on doing an implant and you don't have enough length, like let's say you want to do 13 and you have only 10, so try to take 5 millimeters wide, and that's way you will have enough surface area and you can also immediately load that. But the thing is, you need to learn that you need contact with bone and metal. That's the most important. The surface area will resist anything you're doing. So if you have a 3 millimeter implant, it's almost 1/3 of the surface area of a 4 millimeter implant. Or a 2 millimeter implant is almost 16 times weaker than a 4 millimeter implant. So the wider the implant, the more bone to implant contact, especially at the crest. So the width is important, more important than the length. Something also to remember is power function. 75% of all failures in immediate loading is caused by these people. It's possible to do immediate loading in those cases, but you have to do a night guard for them so that they won't break the implants and they don't give you macro movements that will cause failure of the implants. These are the essential techniques that I'm going to go over with, and hopefully we will go to the clinical part later. So these are the things that you need to know to do in order to do a very good result of immediate loading of dental implants. Full jaws. So the first thing is immediate extraction and implantation. So you have to know how to take out a tooth without trauma, without causing bone loss, and then to do the implant and the bone graft. And you have to know how to open up the soft tissue and close it. Then fat. Fat is the workhorse for everything, especially in patient-specific implants. And fat harvesting and grafting is very important. Connective tissue, it's important, but it's not as, so I can slide this, but it's important especially for aesthetic or for functional reasons, especially in the frontal, the area where the front teeth, and sometimes You have areas where you have like a blackened gingiva, or you have resorption that you don't have the attached gingiva anymore, and you start having mobile gingiva and you want something more substantial for an implant, then connective tissue is a good option, either that or fat. And PRF, platelet-rich fibrin, you can manufacture it and manipulate. You have to know both of them. And I will show you examples on how to deal with it. So, if you don't learn these simple steps, it will result in a failure to immediately load. This is a patient that needed to extract tooth number 15. Yeah. So the first thing is vertical release. I cannot see here, sorry, only here. So the first thing is vertical release. Usually automatic extraction is basically doing with an elevator, or you can also use a forceps, it's your choice. Extract it as much easy as possible. And then you are left with the hole. And the second thing is to drill. And drilling is something that nobody really tells you about it, but don't go for the roots of the teeth. Okay, they are angulated at a different angle from the bone. If you try to do it the easy way and go to one of the roots, usually you're going to have some kind of a dehiscence either in the buccal area or in the palate area. So try to say yourself, I want to do the implant where I want to do it, and I'm going to do it where I want to, not where the root is telling me to. You understand what I'm saying? The easy way is to go to one of the roots and just do the implant, but that's not the good way. Okay, the good way is to take a Zakaria drill at the midline, wherever you choose, and then drill the hole, the first one, the second one, the third one, then you make it large enough and you can put the implant at the right place. You can see it here. In this case, we also did the sinus, closed sinus lifting, it doesn't matter. These are the implants I use in this situation. This is the implant, 4.2 and 13 millimeters. This is the implant. I'm doing everything by hand because this is the only way, especially when you're doing immediate loading, that you can feel the pressure of the bone and the quality of the bone if you want to immediately load it. This is the vertical release and the periostal release, but I will show you another case which shows it easily. Then the bone grafting and soft tissue closure using resorbable sutures. Another case, this is again the vertical release, something that I wanted to show you twice. This is the extraction, this is the tooth, this is the area where we want to drill. Again, we're drilling where we want to and not where the tooth is. You can see the drilled hole. Then we put the implant in place, the bone grafting, and now you release using your knife. You have to be very careful in this situation. I will show you a case of a patient that started to move immediately when I tried to cut the periost, and I was left with the soft tissue at hand. So you have to know how to release. Usually you have to do some kind of pressure with the hand that holds the soft tissue, and then it immediately releases when you cut enough. Then you close everything up. You can close it with silk or resorbable, it's your choice. Fat is the horse. It's very important. It's the workhorse for us. The surgeon must be familiarizing himself with the proper soft tissue manipulation and complication treatment. Sometimes tissue can be torn or lost, and there are many complications that can happen, but the main ones are soft tissue infections, lack of osteointegration, and soft tissue tears, and implant exposure failures. Infection, you have to clean correctly. Curettage, granulation tissue removal, as I showed you prior to implantation, good antibiotics coverage. Many people give the wrong antibiotics. I will talk about it. And watertight closure. You have to know how to release the soft tissue and close everything. Flap tears, sometimes, as I said, it can happen. You can have a cut and that will result in loss of soft tissue. Sometimes you don't have soft tissue because you had a lot of abscess or some kind of an infection, and it causes the loss of gingiva, and you cannot close everything up. So in these situations, you have to know what to do, and I will show you. And nerve injury also, that's something that can happen anytime, anywhere, and you need to know at least how to deal with it. And I'm going to show you what to give in order to treat nerve injury as well. So first thing, I'm not going to scare you. This is not my point. I don't want to tell you that every time you're going to do something, this will happen, but it can happen. Okay, and sometimes the infection can be life-threatening. So always, always, always perform irrigation, curettage, and I'm telling you irrigation twice because I was, when I studied medicine and not dentistry, I came into doing a fellow in orthopedics. And I saw that in orthopedics, when they have an open fracture of the fibula, they have a protocol for every millimeter of exposure, how much water you need to put. So if 1 centimeter, let's say, you need 2 liters, 1.5 centimeters, you need 3 liters. Thank you. And 2 centimeters, you need 5 liters of saline to wash. And we don't have that. And we are working in an environment with a lot of bacteria. So I think I took it from them. Irrigation is very important and nobody really talks about it. So saline, your syringe, whatever you want, but do yourself a favor when you extract, wash, wait, talk with somebody and continue washing. That's very important for the count of bacteria, especially in this situation, which I'm going to show you now. Antibiotics, if you have more than 1 tooth that you extract, if you have some kind of an infection, then amoxicillin calvolonic acid is the option and not moxipen. And chlorhexidine also for cleaning. So this is a patient, a male, 49-year-old. He had 3 babies, 3 children. He had lower jaw floating teeth, huge amount of granulation tissue, and I got a call from his GP, from his general practitioner, that told me, I don't know what happened. I just extracted the teeth and sent him home and gave him oxypen, that's it. I don't know what happened. And this is the case. So I think most of you would say these are very easy teeth to extract. You have some granulation tissue here, so you need to extract and clean everything up, but he didn't. He just extracted, and that's it, and sent him home with moxipen. Didn't suture anything, nothing. And the guy, after 2 days, had a severe infection of the hematoma and the granulation tissue that was left. On the 3rd day, he was admitted to my medical center, Rambam, and they called me and I had to do a tracheostomy, and we started opening up, and we discovered everything was like sand. You could put a hand here, your finger, and it will go through the skin. The skin was like sand. And it was necrotizing fasciitis, and he was admitted to the ICU, and after 2 weeks, he was given antibiotics and everything, and he was discharged, but look how it was finished. So you can see, I don't know if you see the lower picture, a lot of blackened material. This is the black necrotic tissue. So it's only from 2 extractions that didn't clean correctly. No washing, no granulation tissue, manipulation, nothing. So you can see the parotid, you can see the sternocleidomastoid, and some of the muscles of the face. I'm not saying it's going to happen to you, but I'm saying don't let it happen to you. Just do the cleaning and washing and it will be okay. Another case, also something that I treated, a 27-year-old male, healthy, admitted to the hospital following dental implants in this case. It was dental implants in the anterior mandible, and upon admission he had an infection of the mental hematoma. But the doctors noticed that the color of the soft tissue changed to blue. And he said, okay, this is something serious, I want to send him to the hospital. And he sent him to the hospital, and he had early stages of necrotizing fasciitis. The patient received external through and through drainage, so we have to cut the soft tissue in order to put oxygen inside, so the bacteria will die, the anaerobes. We give him IV vancomycin and admitted to the ICU, and after a week later he was discharged. You can see the hematoma. I'm not sure it's 100% the hematoma, but you can see it from the picture. These are the teeth and the implants. And this is the patient. You can see the blue, I think. So this is the patient, and he survived. That's good. Sometimes you can also have soft tissue tears, as I said before, so you have 5 options. In case you lose soft tissue or you don't have soft tissue to cover your implants, you can, if you cut accidentally the soft tissue and you are left with the soft tissue in your hand, it becomes a full thickness free graft, gingival graft. So you can suture it into place, and usually it's okay. So that you have nutrients imbibition, it will survive, and usually it doesn't fail. If you don't have that, and it's not a full cut, but you have a partial dehiscence, you can also use platelet-rich fibrin, which is a good option if you want to have soft tissue repair, because it has a lot of growth factors. And you prepare it from platelets, you take some blood from the patient, you need a centrifuge, and I'm telling you, those of you who think centrifuge is something big, I started from an AliExpress $100 centrifuge. This is what I bought. I wanted to try. So I bought a $100 centrifuge from AliExpress. It wasn't serious, it was the good one, but it worked, and I made some PRFs, and then I started doing it with a better centrifuge. So it can happen. It's not something that sophisticated. Connective tissue free grafting, you can harvest it from the hard palate, the area at the back, especially good for recession cover or gingival tears. Sometimes if you want to make the soft tissue a little bit thicker, that's a very good option. I have surgeons that I know that every time they put an implant, they take connective tissue, and they also use it for making the soft tissue thicker, especially when you have a lot of bone loss, because at the beginning you have the attached gingiva, then the mucogingival line, and then the mobile gingiva. When you lose a lot of bone, you are over the mucogingival line, it becomes mobile. So either fat or connective tissue. It's very important, it's going to save you a lot of trouble later on. Fat grafting, we call it bisha. You call it the buccal fat of ped or buccal fat ped, I don't know the right name. It's especially nice if you want to do gingiva, if you have gingiva loss. If you don't have enough soft tissue to cover, this can become gingiva. This can become soft tissue. It sloughs, it becomes a little bit necrotic, and then it changes to normal gingiva. And the final option is doing nothing. You have to take out the implant, you have to take out the bone, and it will close. You have secondary healing always in the mouth, but you're not going to use the implant. So these are the options. I want to show you an example. This is a patient that was planned for an extraction and immediate loading. This was the time when I was going to dentists to help them. I'm not doing that now, but at the beginning I did. And it was tooth number 12. During surgery, the patient moved and the flap was totally disconnected from the gingiva. So it was held in my hand. So the free flap was sutured into place using silk 4.0, and everything was back to normal after around 4 to 6 weeks. I think 4 or 6, I'm not sure. Anyway, this is the suturing. What you can see here, I don't know if you can see here, that the midline is white and the periphery is red, and you can even see here a blood vessel. I don't know if you can see, I'm not seeing anything, I'm just showing you. Yeah, you can see. So new blood vessels are being created in the periphery when you have a free graft that you put in close. And the midline is white. This is normal. But after 2 weeks, you can see the change. So the periphery is now pink and the midline is becoming red. That means that blood already reached the midline. So if this is the process that you are seeing, that's normal. So that's okay. And this is after 3 months. Another case, connective tissue grafting. Also something that you need to learn, especially if you want to do aesthetics or area of the aesthetics, the frontal skin, the frontal teeth. This is the way to do it. I think there are 2 options. The maxillofacial way and the periodontal way. So the periodontal way is to cut all the way to the bone, to lift everything up, to take the connective tissue and to close the soft tissue back. The maxillofacial way is to take everything out, to go for a table, to cut it and let it secondary heal. Okay, so you can do whatever you want. I'm joking, of course. This is a connective tissue grafting. Implants need good attached gingiva, as I said before, around the implant's head, sometimes especially in severe atrophic cases, in patient-specific implants, the gingiva is all mobile and fragile, and either fat grafting or connective tissue grafting is needed to have better long-term survival of the implants. So this is an example of gingival bed preparation. I will show you. The gingiva is left connected to the palate. That's very important. You do some kind of tunneling. There are many, many systems. I'm going to show you the picture. It's easier. So you cut on both sides. You leave the area of the gingiva where it's the papilla connected. So blood will come from the back and from the front. And then you can slide your connective tissue graft. If you want to recession, I'm not talking about recessions, but I'm talking about the fact that if you want to make this thicker, you have to put it around here and then close everything up by suturing, but the blood will come from the papilla, from the area that you don't disconnect. So this is an example, just an example. This is a patient that came. The problem was, I don't know if you see, but this is black and this is pink. And it's because there is an implant, and the implant exposes the gingiva, and it becomes, it's not aesthetic. It's a non-aesthetic zone, and it's a thinner gingiva. So after the connective tissue grafting, you can see that the gingiva becomes much bigger and pinker, and the result is much better for survival. This is the workhorse, the fat grafting. Very, very important. I'm using it for almost everything. Not breakfast, but almost everything. So the patient was treated, there is an example of a patient that came to me and he said, I want you to save the teeth. And usually I don't do that, because sometimes the teeth, when they need to be extracted, they need to be extracted. But in this situation, the patient really, really, really convinced me, I don't know why. And due to the loss of soft tissue, we couldn't close the soft tissue. There isn't anything much to close. So the buccal area, the molar area was almost totally lost. And both of the teeth were supposed to go out. So I used fat grafting. And the fat, after a while, becomes a gingiva. You can see here the teeth that were, I would extract them today, but he wanted to save it. So we had to clean everything up. You also have some kind of an exposure. So when you put fat, you close the connection, and then you put as much fat, and you leave it connected to the, so it's a rotational flap. It's not a free flap. So it stays connected and still has blood vessels. And this is after 3 months, and then we did some connective tissue, and this is after 6 months, which is a good option. But again, I wouldn't do that today because of the loss of the teeth later on. PRF, we talked about it a little bit before. During sinus lifting, usually you have tears in the membranes. Sometimes the preparation, we can use PRF to close it. It's like a fibrin, it's like a glue. You take 2 to 4 vials of blood from the patient. When I'm using it usually with, I have an anesthesiologist that is doing the anesthesia. So you can ask him if you don't know how to take blood. And then you centrifuge, 2,500 to 3,500, depending on the centrifuge, for around, it can happen when you're doing sinus lifting. And it's very important, I wanted to show you this picture. This is the PRF. It has many types of growth factors. It's not something that you need in order to substitute bone. It will not grow bone at all. But you don't put it inside the socket, okay? It's not good for that. But it's good for soft tissue repair. It's excellent for soft tissue repair. It gives you cells, it gives you bioactive molecules like the ones that you can see, and also extracellular matrix. So it's like a glue that has growth factors. So it's a very good option if you want to use it, and I'm using it especially in patient specific implants, and I will show you later on. So this is a patient that you saw in the beginning, and she had a sinus lifting, and she had dehiscence. So we had to use PRF, and in this case the PRF really adheres very nicely to the membrane. You add and you make a little bit of sticky bone with the bone substitute, and then you can do the implants. You cover everything up with some extra PRF, and you can close up, and usually there is no problems. The last thing is the nerve injury. Sometimes you can see here the patients can come to you, or if the doctor did it, and it reaches all the way to the mental and both sides. This is a patient that came to me, and he wasn't feeling his lower lip. So if it happens to you, and if it happens to you while you're doing a 3D printed implant, or if you're doing any implant, the first thing is to do some kind of imaging, and then unfortunately you need to take out the implants. You administer high dose steroids, usually for 1 week, around 8 milligrams per day. So some people don't have enough B vitamins, so steroids, 8 milligrams per day, 1 week, complex B, and follow-up. Usually after 9 months, if there is a damage and it's left, it's final. So 1997 was the day I arrived to India. I came to Main Bazaar, New Delhi. I'm going into the Main Bazaar, and it's like a bombardment of information. Smell of the, how do you call it? The one that you ignite, the smoke, with the smells. All the carpet shops have it. Incense. So the smell, and then the sound, beep, 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 beep. And then the cows in the street, and the pig, I think there was also some, and you have to be careful from the cow shit and everything. And I said, okay, the first plane, I don't care where, I want to fly. And I flew to Leh. So the first day, at 1 o'clock at night, I flew to Leh. And I continue after the lecture. Okay, to Leh, the first day, I'm arriving to Leh, and I'm a big boy, 22 years old, I have money, I'm strong, nothing will happen. And then I'm walking, and I'm going to the guest house, and I'm putting up knowledge so far. Now that we know immediate extraction and bone grafting, now that we know how to immediately extract and implant, the fat grafting, connective tissue, platelet-rich fibrin formation, and kind of proper infection control and complication, at least we know what to do, then we can start thinking or talking about immediate loading. And I think it's a great opportunity to take a small stop and finish all the problems here, and then we continue in the second part. If you have any questions for the first part, you can speak with me, and if not, we can eat or drink or whatever there is there. Small plates, yes. Yeah, small break. That's what I'm saying, I think. Thank you very much. Be able to use sophisticated and more advanced technology like fat grafting, very slow. Connective tissue, especially for aesthetic reasons, and also for the thickness of the result. I think the opposite. You can leave there and close here because nobody hears me. PRF preparation also very important for, especially for patient-specific implants, but some other forms of like sinus problems and sinus tearing also can happen. And proper infection control. As I said before, it doesn't work well. As I said before, the proper infection control complications won't happen to you immediately, but please clean well soft tissue, the granulation tissue, wash as much as possible, and you will have very good results. I'm talking about 99% success rate. So the protocol. So the protocol is my protocol, as you remember, the original protocol is 14 days. So I'm doing it in 24 hours, sometimes 36 hours. That means that the patient arrives to my clinic and he's doing the surgery. Usually the surgery takes around 3 hours with an anesthesiologist. He goes home, comes back after 1 day, and he receives the teeth. The teeth are not PMMA, they are not just acrylic, they are metal that is connecting all the implants, all the multi-units together with the T-bases. You understand okay. So all the multi-units are connected with the metal. It can be done using CNC or the invisible wax technique. I don't know if I'm saying it correctly because it's in Hebrew. But my technician is doing it in 24 hours, which is very good. And the teeth are made from Ivoclar composite. So it's a composite metal restoration. You can do it also in, but you don't do it in PMMA. No acrylic. Acrylic is for teeth. It's not for implants. If you do PMMA, just acrylic, the results will be when you eat. If the patient will eat on the left side, all the pressure will be on the left side. But if all the implants are connected, when he's eating on the left side, the right side is also participating in the process. So all the implants are together like ants, they can lift something together like a leaf. But if they are separated, you will have usually failure of the implant that is the most distal. So both sides, if you're doing a full jaw and you're only using PMMA, acrylic, as I say, the last implants will have all the pressure, all the suffering, and they will be, you will lose them after half a year of waiting. So if you're doing it correctly, like I'm showing, it will be a good result. So, as we said, extraction of the teeth atraumatically, curettage, irrigation, and bone grafting. Then we place from 6 to 8 implants for composite metal temporal restoration, as I said now. Then we put the multi-units and we close them, 35 Newton centimeter or 30, that's also okay. Transfer the connection, we connect the transfers and then suture the tissue. And this is important, you suture the tissue at least when you start to doing surgery, as I suggest for you, you do simple sutures. Why? Because if you do continuous, and you take out the transfers, what will happen? The soft tissue will close, and you will start looking for the multi-units, and it will take you like 1 hour only to find the multi-unit. So if you're doing simple sutures, then everything stays in place. Everything I'm talking about, you're going to see clinically now, so don't worry if you don't understand completely. Then we take the impression, the vertical dimensions. That's the most important part for the beginners. If a patient arrives with some kind of a prosthesis and you think the way he looks is okay, how do you know it's okay? The last third should be more or less like the other thirds of the face. So if the distance between the nose and the chin is normalized and he looks okay and he likes the way he looks, you can transfer this. So you make an X on the nose and an X on the chin, and you register this amount of like 5 or 6 centimeters. And then, during the operation, when you do take the vertical dimensions, when you don't have teeth in both jaws, then you can use this same distance in order to create the new teeth. I hope you understand. And then you have to do, during the operation, the centric. You have to know exactly where the midline is, where the lips are, where the smile is, and where the canines are. Canines usually are in the thickness of the nose is the canines. Something is about to happen, I don't know what. Let's wait. I'm excited. Okay, so close the multi-units with healing cups. And continue. Sometimes, I'm telling you sometimes, now I'm not doing it, but this is an old lecture, so sometimes I'm sending the patient to the technician, so the technician knows what you want and how you register everything. If you register correctly, the technician will see it because he will try to do like a teeth alignment and to see if the VD was correct, vertical dimensions is correct, if the lips are correct, if you have 2 to 4 millimeters of exposure of the teeth only, and everything that you wanted to do. I know that I'm a surgeon and I'm speaking to you about rehabilitation, but I'm also did 2 years of rehabilitation, and I'm trying to do my own rehabilitation, and the results are usually much better, because when you do the implants and the reconstruction, you are responsible for both, and the results are much better. So that's why I'm speaking to you a little bit about that as well. Following usually 24 hours, the patient is coming to the clinic and receiving the teeth that he wanted, and then you close everything up, and around 30-35 Newton centimeter torque, you have the ratchet, you can know exactly how much. And you adjust, as we said, group function. Okay, you want all the teeth to touch, you don't want areas where you don't have any pressure, because again, even though you are doing some kind of a prosthesis that has metal inside, it's like a PFM but with composite, but still you want some kind of connection between all the teeth of the upper jaw and the lower jaw without any canine protective occlusion, for those of you who remember. The follow-up every 2 months until 6 months, and then you can do the final restoration. So the surgical procedures, step by step. So the first thing, as we said, is ultra-aromatic extraction of all the teeth. I won't be able to see. Okay. Doesn't work. Okay, it works. From the upper jaw and the lower jaw. Then the drilling. This is also very important, because what you can see here, that I'm trying to drill very, very palatally. Why? Because the buccal bone usually is gone, sometimes, not always. So you want your implant to stay in bone, so you try to do everything as much as palatally as possible or lingually as possible. So try to be close. And another thing is, you don't want the connection will be on the edge of the tooth. So you want everything to be inside. We are doing screw retain implant restoration. Okay, I'm putting all my implants with hands, only with hands, so I can feel the bone. When you're doing a guide, the problem is that you don't really feel the bone. So everything is what the technician did. If you did it correctly, okay. But if you didn't, you have 100% rely on them. So when you're doing on your own, and you feel the bone, and you feel that the way the bone enters, the implant enters the bone, you have much more stability, and you can change the angulation sometimes if you feel that the bone is too soft. This can happen. And if you feel that the bone is too soft, and it can happen a lot, so you change the thickness of the implant to 4.2 or to 5, whatever you want. That's why you need to feel the bone. That's important. And this is the lower jaw, this is the final upper jaw, this is all the implants. And then the multi-units, you can see the distance between the buccal area and the implant. So you have a lot of space left, because you can put bone there, but usually you might lose some, so it can happen. Then the transfers, this is a closed tray. I'm not doing now only open tray, but you can start with closed tray. So first, before you close everything, before you put the bone, first you put the multi-units. Then you put the bone, and then you close with simple sutures, okay? If I would close this continuously, and then I'll take out the transfers, everything will collapse, and I would not be able to find my implants. Okay, so it's important to see it simple interrupted sutures. You can see also the maxilla as well, at the top. You can see how much bone in the buccal area is left. That's important also for aesthetic reasons, because the connection is very far away in the palate. And if those of you who can see very good, you can see that on the right side of the maxilla, you don't have buccal bone at all. So that wasn't an atraumatic extraction. So I did something wrong. I did an extraction, and I might have been moving the teeth too much buccally, and I got part of the buccal bone with me. So it can happen. That's why you need to try, again, everything palatally is possible. And then close everything up after you put bone grafting, and cover screws. After the cover screws, you take the vertical dimensions on the cover screws with the registry that you did in the beginning, the vertical dimensions. I will do it again and again. You will eventually understand, don't worry. So I'm going back to the protocol that we spoke about, this time with color coding. So the easiest thing that you have to do is, and in these cases you need specialized 3D printed implants. So from 10 millimeters above. The first example. So this is a 49-year-old healthy female. The problem is it was periodontal disease and caries and poor oral hygiene. She was a class 2 and we want to change her to class 1. So we don't want her to stay in class 2. The teeth were all mobile, most of them level 2, level 3. It means you can take them out with your hands as well. And the plan is to do a total clearance, 10 implants in the maxilla with sinus lifting, and 8 implants in the mandible, reconstruct part of the implants, like 6 in the lower jaw and 8 or 10 in the upper jaw, depends on the quality of the bone. In this situation, due to the fact that she was periodontal, the bone was soft a little bit. So I had to put what happens when you have soft bone. You need more bone to implant contact, so you add more implant. That's not something you always do. But in this situation, the upper jaw was very weak, so I need to put more implants. I know that it becomes more close together, but if you have enough distance, 2 millimeters between implants, that's okay. And usually what helps you is the multi-units, because when you can put a multi-unit in 2 implants, that means that the distance is okay. If you can't, that means it's too close. And after 6 months loading, we did the final restoration, ceramics. So this is the patient before the surgery, the pre-surgical photograph, and you can see the photograph. And you can see that all the teeth needs to be taken out. We cannot use them, and they are not functional in the mouth. Some of the implants, I think the left one, we left, but I didn't use it as a part of my reconstruction. So I'm not counting the implants that she had that were good as part of the reconstruction. So this is the reconstruction. You can see the implants are a lot. It's not supposed to be like that, but it's because the bone was very weak. So the backwards were normal implants that we didn't reconstruct, and in midline, too many implants, but the results, she was class 2 and she is now class 1. That's what she wanted, and this is the aesthetics she demanded. And I can see, I hope it will work. I can show you she's speaking. This is exactly 36 hours after the surgery. No, we can't hear her. Anyway, she's telling in Hebrew, so we won't understand anyway. So she was speaking after the surgery. So this is only 1 day, 1.5 days after the surgery. And this is 8 years follow-up. This is with the final ceramics. This is Ricky. She's 60. She has severe neglect. She was coming to any dentist that can help her, and they put here a lot of bulk of acrylic. I'm sorry that you can't see that good. From here it's much better. But a lot of acrylic in the front area and the lower jaw. And this is the extraction, the bone grafting, the immediate implantation, and loading. I will go through step by step, don't worry. And this is the final restoration after half a year. This patient came to me, and I'm showing it mainly to the periodontal friends of mine, because sometimes they say you cannot do anything now, you first have to extract, or sometimes clean everything up and then do the implants. And I'm telling you that I did more than 200 cases, that you can do everything in one go. But you need to clean very well. You have to wash everything. You have to take all the granulation tissue and cut it like cutting paper. Okay? And in this case, you have to cut everything and clean everything as much as you can. And then you do the immediate loading. And the patient in this case had a doctor that referred to me, so she went back. And this is the final restoration with the implants. I don't know if you can see, it's far away, but he chose to do acrylic metallic restoration, so it's okay. I'm showing you this case because sometimes it can happen. The patient arrives like this, and she's doing the surgery, and she comes in a few days and she looks like this. This is a hemosis. This is something that can happen and will happen, and it's normal. You will see in all cases that I will show you some kind of hematoma. You don't have to be afraid of it, okay? But you have to acknowledge it, because this is normal. Okay, it can happen. It's not something that's supposed to happen, but if you do implants and somebody has kind of a bleeding, but it's a normal guy, so, or a woman, so she can have bleeding. She doesn't have any problems with feeling of the lower lip, but this is a hemosis, which is more or less normal if you have dental implants. That's why you need antibiotics, because the blood is a very good thing for the bugs inside our mouth. They like blood and they can grow, and we want antibiotics so that they won't grow. But you have to distinguish this from this. So this is something else. This is blood disorders. So thrombocytopenia or blood thinners or liver disease. The thing that you have to know is you have to check it. So I usually send the patient for the PT and PTT and platelets count. So if you have less than 90,000, don't do that. If you have a PT elongation or a liver problem, usually because the patient is drinking too much or he has an hepatitis or some kind of a disorder, then it will cause a rise in the PT, in the INR. And the bleeding, this is the patient after surgery when she didn't know she was problematic. She had thrombocytopenia because of ITT. So in this situation, the patient is starting to have hematomas in different areas that were not treated, like the eyes, and it continues to grow, and she says it's growing and something is wrong and blah, blah, blah. And then you understand that this patient needs to be rechecked because something was not correctly analyzed. And eventually it was a lab problem, and we found out the problem, she had thrombocytopenia, loss of platelets. This is Shimon. Again, here you can see the vertical dimensions when I intake them, when I take it. So I look at his teeth and they look okay for me. And I look at his vertical third, the last third of the face, and it looks okay, and he likes the way he looks, he doesn't want to change. Usually the ones that want to change are the women. They say, I want this a little bit back and a little bit forward, A1, A0, etc. So these people are okay, they just want the teeth, and you do the teeth, and there is no problem with the patient. You can also treat people who are dental phobic with this type of protocol, because it's 24 hours and the patients don't need to go through all the suffering. And these cases are two patients that came to me that are dental phobic. This one was also a functional dental phobic. He wasn't coming to anyone. His teeth were all broken and destroyed, no vertical dimensions, so I had to change everything. And his daughter was getting married, and she said, you're not coming to the wedding until you fix your teeth. So we did the teeth. And the second patient, you can see how frightened he is. He was eventually able to go into the clinic, but usually what we do, we give him some kind of sedative before, outside the clinic, and then he can enter, and you see 24 hours he's very happy, because it's 24 hours. And it's a suffering that anyone can withstand. That is something important. Another thing I wanted to show you, that you can change the way the patient is looking, because I'm a maxillofacial surgeon, I can do orthodontic surgery, but I can also do orthodontic surgery with implants, and you can do it also. So this patient comes to me and he says, I can't find any women. They think I'm stupid, because I'm like that, and the upper jaw is thin, and the lower jaw is thick, and it's outside. The teeth are outside, and they are moving, they are mobile, they are not good quality. All of them were moving, all of them were starting to go out more and more. And what we can do here is when we extract everything, instead of putting a 17 degrees angle of multi-unit, we put a straight one. And then we can go out of them and make the maxilla bigger and make the mandible smaller. And the result is a different person. This is 24 hours. And 2 months later, he found a nice girl. He didn't get married, but he found a nice girl, so that's a very good option. Another person with dental bruxism, and the cause, you can see the diastema, it happened because he had so much power in his jaws that everything started to break. Not only the teeth, but part of the jaw itself was starting to move, so the teeth were going anywhere, and they were mobile. And this is the immediate loading, and low is the final restoration. You can see it here. And you can see another patient with bruxism, with the teeth that are mobile, and 24 hours later. And another case of a patient, again, in this case, the VD, I don't have it. I don't have the vertical dimensions because he doesn't have an upper jaw. He didn't use any. So I can ask him to open his mouth as wide as he can, close his eyes, and start closing until the lips touch. When the lips touch, that's the VD. If you don't have a jaw, if you don't have two jaws, that's the same. You can do it also with a face bow, that's okay. But I'm telling you something that works very, very well for me. Close your eyes, open your mouth as much as you can, and start closing slowly, 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 until you start feeling the lips touch. When the lips touch, take the registry, that's the VD. This is a woman that came to me with the tooth in her hand. All of the teeth started falling, and she had a boyfriend who didn't know that, so she was working with the N95 mask. And I told her, but there is no corona, what's your excuse? And she said, I'm telling him that corona is back. And you can see 24 hours later, she was very happy, and he didn't know. This is another patient with bruxism, a very severe bruxism. He was destroying his teeth and a lot of breakage, and he wasn't going to any dentist and everything. And you can see again 24 hours later. And this is a case of 4 3D printed implants. I just wanted to show you how much hematoma can happen. And again, in this case, she had ceramic restoration on implants that all of them failed, and she was walking like this in public. That's the problem. And again, I don't have the VD, I don't have the projection of the lips, of the maxilla, so I need both of them. So to get to this, after 24 hours, you need not only the vertical dimensions, which I showed you how, but also the horizontal dimensions. That's also very important. And you do it usually with your hands or with some kind of a putty, if you want to put as much as possible. And in this case, the problem was the midline. So they made an implant around here, in the midline. So everything went to the right, and she had a crossbite on the left side. So what I did was extract the implant, do different implants on different size, and you can see that the results are much nicer and much stabler. A little bit about statistics. So from 2016 to 2021, I had 55 patients, all complete jaw immediate loading, 36 females, 19 males. I had 14 patients with diabetes. And you can see what happens when these patients are treated with, first of all, we extract all the granulation tissue and all the infections. So the body stops fighting it. So it starts fighting with the diabetes. And then he starts eating. He can eat a salad. He can eat food that needs to be chewed, and he doesn't have to eat always fattening and very paneer and whatever. Things that are fattening and fast to eat. So the diabetes went from 8.4 to 7.1 A1C, which is a good result. I had 8 implants that failed in one patient because no communication, no rapport. So the results of immediate loading is 99.2 in my hands. Okay, it's not in your hands, but it can give you an idea, because when I'm doing normal implants and I'm giving the patients prosthesis, I have a lot of exposures of the implants, and food is going inside the exposure, and then the implants start to fail. So this technique, as we said before, causes bone formation around the implant because of micro movement. Shortly, the body reacts. Okay, now I have pressure, and I want to create more bone to save as much as possible. And with the wrap situation, it's much accelerated. So you understand now why I needed the information in your heads. It's like being in space. When you are in space, there is no pressure, you lose bone. When you come back to Earth, pressure, now you have bone. Now if you put more pressure, you get more bone. Okay, that's basically the technique. Okay, so now we go away from normal bone and we reach the shorter bone, so 5 to 8 millimeters of bone. So this is a 52-year-old male. He was 15 years edentulous. He only had dentures. So the planning here is to do 6 short pyramidion implants, the specialized implant that you can open. And usually when you put a 5 millimeter and you open it, the surface area becomes like an 8 or even a 10. And if you put an 8 millimeter, it becomes like a 13 millimeter length implant. Okay, you understand what's happening? So if I put 6 short implants, I'm actually putting normal implants when I'm opening it inside the bone. So 48 hours later, he received the prosthesis, the follow-up. So this is the patient. You can see that he doesn't have, I will make it a little bit bigger, you can see that he doesn't have a lot of bone. So if you look, I don't know, I don't see, you probably see better, I can see it here. So it's around sometimes 9, sometimes 6, sometimes 8, but it's not a very big amount, so it's very short. But you can reconstruct it with implants, but they need to be specialized. You can see that the first thing that we do is we take the vertical dimensions because he had prosthesis and they were okay. So the first thing, you take the VD and the patient and you put it on the side. Then you expose with the holes where you want to do the implants. Then you drill. In these type of implants, you have to drill with stoppers because it's so short that you don't want to miss the target. So you can use short drills that have stoppers, so you reach the bone and you stop. This is the implant when it is closed, and after it goes into the bone, it has like wings here, that when this open, the wing connects the 2 parts, so it becomes like a pyramid. Then you put all your implants in place, and this is the machine that opens it inside the bone. So it doesn't matter because the company is bankrupt. No, actually something happened and she's not working anymore. But if you want to, if you're an entrepreneur and you want to do it, I don't think they have a patent now, and it's a very good option to go into if you're into business. It's a very good implant. So then the multi-units, and you also sometimes can connect to the multi-unit something around here, like a small thing that you can use to measure resonance. Resonance is measured if you want to know exactly how stable the implant is. Before the resonance and after the resonance, when you open the implant, it becomes much, much more stable. But all of the implants were around 74, 75. There was one 65, but above 60, that's okay for immediate loading. Then you connect the transfers, the open tray, close up everything with simple interrupted sutures, as I said before, then imprint, send it to the lab, and the patient receives after 48 hours the teeth. And you can see the panoramic view, the upper jaw. This is before you receive the teeth. Okay, now we reach the best part, the 0 millimeters. Okay? So, before, around 15 years ago, we did not have this solution. We did not have 3D printing, and in severe atrophies, we did what we had to do. So we can do bone grafting, nerve lateralization, vertical bone augmentation, or lateral bone augmentation. That's basically what we could have done. And I'll show you a little bit of examples, so you will see the difference. So this is a female, a woman, that came to me from Lithuania to Israel. She was 50 years old, she was healthy, and she had vertical mandibular ridge deficiency. The vertical bone augmentation, we used a titanium reinforced membrane, and we took human bone graft and her own bone graft. So autograft and human bone graft with a scraper. So before the surgery, I want to ask you just one question so I can see if you know how to read the CT. How much bone do you have here for an implant? If anyone can tell me, more or less. Anyone? 8. Okay. Okay, it's written 10, but you don't have 10, right? That's what you're saying. You have around, I think, more like 6 here. Because if you look correctly on a CT, first of all, I wouldn't recommend you to try to reconstruct this, because you can see, if you look up there, if you put an implant and you put a reconstruction, you can see that the ratio is 2 to 1. That's not a good restoration. So you better try to do something with more contact with bone. So you can either do a 3D printed one or just create more bone. Okay, so if you look closely, you can see that this is the lingual bone that you see here. So you actually have around 6 millimeters. When you open up, you will see that. So reading a CT, that's very important. The technician will give you 10 millimeters, you go into the surgery and you receive either the nerve damage or 5, 6. Okay, so in this situation, you use the membrane. This is a titanium reinforced membrane. First we have to extract the tooth that was there, and then we can create more bone. So this is the result. If you look at the CT, you can see before and after we gained 14.22. So from around 6 to 14, that's a lot. That's 8 millimeters. Okay, that sounds good, no? So why am I talking about? But there are many disadvantages. So the first one is 5 to 6 months waiting time for the vertical bone augmentation. 3 months waiting time for the implant integration. You always have exposure of the titanium membrane. Almost always it occurs, and you need very good cooperation with your patient. So that's also something that you need to do. It's very expensive. And I don't think everyone can do it. Another thing that can happen, that we do, is nerve lateralization and bone grafting. So this case, this is a patient that from the age of 16, she didn't have any teeth. You see the amount of bone that is left in the mandible, it's atrophic at all. So in this situation, before the age of 3D printing, the only thing we can do is this. We take bone from the calvaria, we take out the nerve from the, sorry, I have to walk all the time. This is the cutting of the nerve from the canal, and this is the nerve, and this is just a red string, so I can see it. And then we take the bone from the calvaria, we cut it in 2, half on the right side, half on the left side, connect it with screws, wait a little bit, and then you can do implants from one side to the mandible to the other side, all the way. You can see it here. So all the way from one side to the other side, after the bone grafting was accepted. And this is after 10 years. She was stable because the bone was a basal bone, so the implant, even though the implant had some exposure, it stays in the basal bone. So it stays all the way. So if you lose all of your face, then you will lose the teeth as well. So the teeth are part of her skeleton now. But what are the disadvantages? Again, it's a general anesthesia in a hospital setting. You need second site for bone grafting, calvaria. You have to wait without teeth and without a prosthesis 6 months for the bone. So she was walking without teeth. Another waiting time for implant integration, another 3 months. So total after the exposure of the implants, around 3 surgeries. It's very expensive. And you have another potential of nerve damage, so it's not an advantage. What are the advantages of the patient-specific implants? First of all, it's faster. It's cheaper than the alternative. Can be done in a clinical setting, in your clinic. No second surgical site, so you don't have to take bone grafting anywhere. Less chances of nerve damage compared to nerve lateralization, of course, and can immediately load if needed. So the patient comes with no hope and can go back home after one day with teeth and a hope. Things to consider: in severe atrophic jaws, you can use it, but you have to use it wisely. The entire jaw can be covered with these type of implants, but you have important notice. First of all, you need the fat. You have to create something like dermis. Dermis is the layer underneath the epithelial layer. So you have to use PRF, fat, and traumatic extraction, as we said, minimal cantilever as much as possible, so you don't want teeth that are floating behind the implant, and groove punction, we said already. So all the principles are needed, plus. So this is a case of a woman called Malka. She went to any hospital that you can think of, and they tried to do something. The resolution is not so good, but you can see that she had some bone grafting in every place that she had. And also they tried to do, and they were able to do some kind of all-on-4 in the lower jaw and something in the upper jaw. But the implants were very bad. They were all mobile and they were all very thin. They were around 3 millimeters, so not much to use. So the only implant I could use was the right one around the canine area, number 13, and the rest was lost. They were not usable. And you can see that the bone is so thin that you don't have any bone to adhere to. So you can only do something like a 3D implant. So this is the patient before the surgery. She has something that is called pseudoclast 3, which means that the maxilla is posterior and the mandible stays the same and looks anterior. And this is the planning. We will plan a 3D printed implant in the upper jaw with connectors, multi-unit connectors, and also in the lower jaw, a 3D printed implant in the lower jaw, and I will use the implants that she has already. This is the upper jaw. You can see all the connectors and where the screws are going to be fitted in, and the lower jaw as well. You can see the nerve first. You will see the nerve in the lower jaw, 1 minute. You can see where the nerve is compared to the implant. So 1 above, 2 or 3 below. That's the good option. This is after you produce them, you receive them, and the surgery. The first thing, you expose everything, then you find the implant to be passive on the bone, and then you start connecting. You've seen the movie, so you know how. Then you put all the screws in place. You can see the implant that I decided to leave, which is not so good, but I like to have implants and 3D printed ones together. So this is the right side, this is the left side. Some areas you can see the hisses, but it's okay. Then we uncover the fat, and we start covering the implant with the fat. Then we produce PRF. Then we put it in the interface where we want to close everything up. You understand why I needed you to understand PRF and fat now. This is the way to do it. And then you close everything up. These are the multi-units, the cover screws. Then you take the impression. I left the implant that she had. Putty wash, normal putty wash. This is the impression. You send this to your technician. Lower jaw, same thing. You expose the bone, connect it, up, right and left. Then the transfers, you close everything up with the bone grafting. You take the impression, putty and wash. This is the impression, cover screws, and you can send her home. And this is the final 24 hours later restoration. And this is the way she looks. And I think today it's 3 years now, but it's at least 2 years ago, the picture. So 2 years, final stable restoration, and she can walk, eat, and talk, and she's very happy. And again, these people are depressed. When they come to you, people tell them, that's it, you don't have any option. Either take from here and maybe walk without teeth for a couple of months, and let's see. Another case, this woman had 30 years without teeth. She had a paper bone. It was so thin, you could puncture it with your hands. In this case, we did different implant, but the same concept. You can see the hematoma on the right side. And she's now 3 years later. This is the picture. Very happy, she's walking, she's eating, no problems. Yona. I wanted to show you Yona because this is actually the case of the lateralization only in 3D printing. So you can see the mandible, and you can see the amount, I will show you a little bit bigger, you can see the amount of bone that she has. Anyone will want to put implants here? No. You can see the nerve, it's exposed. So her bone is so thin that if you try to put an implant, even if you try to do a lateralization, I wouldn't put an implant. It's too thick, it's going to break for sure. So you can see that it's very, very close to the situation that we saw 15 years before. So this patient is almost like this patient, but this time I'm going to reconstruct her with 3D printing, not nerve lateralization. So this is the patient before the surgery. You can see the amount of loss of the bone, and this is the planning. You will be able to see the nerve here on the top. So I know that I need to be careful where I'm cutting. And a lot of areas in the lingual is used. You use wherever you can, like ridges, and you catch them, but it works because now the bone is even stronger because it has metal cage around it. And this is the patient after receiving the teeth. I don't have a picture, but she also 3 years later, and she looks the same, so it's like that. Dalia is a case of a 2.5 pack smoker. So she was smoking from the age of 16. And it's important because if you want to do general anesthesia, or if you want to do just in your clinic, like conscious sedation, he needs to stop smoking, and it's a good option for you. But it doesn't stop smoking before surgery, 8 weeks before surgery. 6 weeks, don't stop, because she will all the time. 8 weeks, the lungs are clear, you can do it. So she stopped smoking, 2.5 packs. After 8 weeks, we did the surgery. So there were many attempts in the hospital, 3 times, and all of them failed. Some of them succeeded in the area of the 18 numbers, so the wisdom tooth at the upper jaw, but it wasn't so good for reconstruction. She stopped smoking. We did a 1 piece, because in this case, we needed a lot of stability because we needed to go out of the maxilla a lot to give her back the protrusion of the lips. So it was so much, so we needed to do a 1 piece, which means we connect from zygoma to zygoma, 1 piece of all the implant. Then immediately load, I'll show you. So this is the lower jaw, it's the same as before, with 4 implants at the front that she had already. And this is the upper jaw. We changed it a little bit. You can see the old option. It's 1 piece. It looks like a butterfly from one side to the other side. And the implants that she had were okay, so I used them. So it's not the best ones, but most of my reconstruction is on this one. So it will become red, and this is the almost final reconstruction, but the final result. I'll show you how it looks. So it looks like this. again, upper, lower, and the surgery. So you expose everything. This time you need to expose a little bit bigger. The first thing you need to do is to put it on bone and to see that it's passive, because if it's not passive, when you start to close here, the other side will lift. So you have to make sure that it's sitting, and it's sitting passively on the bone. And in this case it was passive. Then we take the fat, after we connect everything, close everything, then we take the PRF and we close on the PRF. So the PRF needs to be in the interface of the closure. And also I use the implants at the back. You can see the different transfers. Lower jaw, the same thing. I'm using the implants that she had. I'm changing to multi-units, and I'm putting everything together to see that there is kind of a parallelism. And this is the patient before with the pseudo class 3, a serious pseudo class 3. And this is her, this picture, no, this one is after the surgery, this one is 3 years later. The picture of the right side, last time. Jacob, a healthy male, looks like a fisherman, but is not. Many attempts for rehabilitation. I wanted to show you him because he had a lot of dehiscences due to a lot of sinus lifting attempts. So you can see, I don't know if you can, but when you look at the maxilla, no, you don't see. You have a lot of areas where you don't have enough bone. So you have dehiscence, which means connection between the sinus and the oral cavity. I will show you in the planning. So you can see the planning, you can see a lot of dehiscences. This is the planning. You need to reach a higher area of the nose, and also I asked the company to make me a lot of holes, more than I needed, because I don't know the quality of the bone, and if this dehiscence is connected to this bone, maybe when I put everything, this dehiscence is much larger, because the CT can show you not everything, with a margin of 0.5 millimeter. So sometimes you need to make sure. So I was planning it like that, and I'm telling myself, okay, I'm going to do it like that I'll have enough holes to use. Maybe I won't use all of them, but at least some of them. So the dehiscence here, another here, and you can see it also in the live patient. This is him after the surgery. I didn't have a picture before, unfortunately. So exposure, you can see the first dehiscence, then you put the implant. You can see that the reconstruction the planning was very close to the real life. You can see that all of the screws in the palate was used, and it was a very stable implant. Also in the other side, again, there was another dehiscence over there. Then we took the impression. You can see here the lower part. This is the buccal area, the first screw, the second screw, and the third screw. All of them needs to be under the canal. This is the basal bone. Then we put 3 normal implants at the front, connect everything, do the impression. This is the restoration, metallic composite restoration. And this is the patient when you receive the teeth. And this is the panoramic view if you want to see. It's mainly 3D printed implant with some normal implants in the front. Wherever you can, do normal implants, only if you can't. So to conclude, I'm going to show you an example of a case with all 3 situations. So all 3 solutions can be also in one patient. And this patient was unique because she was a woman and she wasn't so cooperative. She was, but she had problems, mainly monetary ones. So she was a very complex case. So in the upper jaw, she came to me and she said, I'm going to get married, my daughter is going to get married, and I want to look good, and I have a prosthesis with an implant that is painful for me. I need something. So I told her, like, yeah, I can do an immediate loading, but you don't have enough bone, you have like 5 millimeters. So So I can do a 5 millimeter implant that will open up, and maybe if I have 4 of them, it could last for 1 to 2 months aesthetically. But then you have to come and I'll do sinus lifting and you have to connect everything together. She said, okay. 2 years later, so she did the immediate loading and went away. And with 4 implants, 5 millimeter, that's it. Everything was okay. So we did sinus lifting and another 6 implants, and in the lower jaw, 2 patient-specific implants at the back, and short implants and normal implants at the front. Finally, she received the composite metal restoration and follow-ups, 8 years now. So she arrives like this. You can see that the implant is failing, and she doesn't have enough bone at the front. The planning is to do 4 5 millimeter pyramidion implants, immediately load, and wait 2 months. She went 2 years. She came back, I did sinus lifting, 6 implants at the back, connect everything. At the lower jaw, we planned we could do 3 normal implants and 1 short one because not enough bone, and 2 3D printed at the back, and also immediately loaded. So this is the beginning. We did 4 pyramidion. You can see the amount of bone that is left. So only 5 millimeters. We cannot do more. And this is after the immediate loading. PSI at the lower jaw. This is 1 pyramidion, 3 normal, and 4 pyramidion of 5 millimeters. That's it. After 2 years, this is the picture after 2 years, and then she came back. This is the immediate loading. It's a couple of months later, and this is the sinus lifting. She has already have teeth, so I can do sinus lifting at the back and wait. And this is 8 years later, after the immediate. So you have everything here. You have the sinus lifting and the teeth at the front, so they can help me, so the patient can wait because he has teeth. 5 millimeter implants, also at the back, and 3D printed implants. So everything that can be done was done, and also almost 9 years now of follow-up, not 8. From 2016 to 2021, I had 25 patients, 61 patient-specific implants, 21 females, 4 males. I had a couple with diabetes. The A1C started from 8.2 and went down to 7.3. Not all of them gave me the results, so I don't have everybody. 3 implants in 2 patients failed. 1 I did second time and it was successful. This 2 I failed, they failed. I had exposures, 5 patients, so 8 implants were exposed. And the exposure is not a failure, but it's a problem. So if you don't put fat, usually it happens when I don't put fat. So when you don't put the fat, you get exposures, and sometimes the implant starts to give them trouble. It stays for many years, but it gives you problems. So I cannot say it's a failure, but it's not really a success. So if I'm talking about just success, teeth, it's 95%. But if I'm talking about exposure as a failure, it's 82%. So I can say that between 80 to 90% success, these type of implants. Take-home massage. I know that I'm writing it wrong, but it's message. Today, using updated technology, we never say never. So every case, no matter how difficult, can be rehabilitated in your clinic. If you have normal, you can do normal implants, short implants. If you don't have the specific ones, any short implants can be done. If you have extreme cases of bone that's 0 almost, you can do 3D printed ones. Any surgeon that wants to do immediate loading needs to learn the basics, fat harvesting and grafting techniques, platelet-rich fibrin preparation. I told you $100. AliExpress, start with that, it's very easy. Connective tissue graft, harvesting and grafting, extraction and immediate implantation, that's the first stage. and dealing with infection, atraumatic extraction for bone preservation, for implant stability, complications like lack of soft tissue coverage, and tears and nerve injuries, and bleeding. Everything we spoke about, I hope now you understand why we asked, why am I doing that? And that's it. Thank you very much. And if you have any questions, you can take my email and speak with me. Thanks. Zygomatic implants, I don't like it so much. There is two reasons. The first one, if you've seen the patient-specific implants, the advantages of them compared to the, I will tell you differently. The zygomatic implants, when you insert them, this is the same place where you also connect to them. So the internal hex is the one that you insert, if you want to take it out, and if you want to connect. And if this part breaks or becomes dull or you cannot use it anymore, you lost the implant. So the connector is also the place where you put the implant in place. These type of implants, the connection is different from the stabilization. So the connection and stabilization are two separate situations. So if you have a problem, like you broke a screw, which is a big problem, you can take the implant out with the screws out. So that's easier for me because I had cases of patients where they came to me and they wanted to take out a zygomatic implant and it was more or less in the orbiter and the head was broken and I couldn't. So I had to cut it all the way to the bone. And the thing that was left in the orbit left in the orbit. So that's a big problem. I don't like the fact that I can't take out something if there is a problem. And you need the guide and other problems. Freehand is hard to do. And you need a lot more than in this situation, which I like to do and it's easier for me.
And do you do pterygoid implants?
It's the same, yeah. Pterygoid I did, a couple, yes. That's okay, I can do it.
Thing, sir, in most of your cases, the implants are placed axially. Do you prefer not tilting them to increase the length of the implants?
I don't understand the question.
The implants are placed straight.
Yes.
Can
yes, you can do it. You mean angulate in the back? And yeah, it's possible. If a patient arrives and he says, I don't want to pay for sinus lifting or I want you to bypass the sinus, then we do at these areas at the back, and also when you have a mental area also at the back, like all on four. It's the same technique. I'm doing a lot. I think one of the cases there was the woman with bleeding, the hematoma. You saw that I did the angulation, but I don't do it a lot. If you have enough bone or enough implants, I don't need it.
Anyone has any questions?
I saw many of your cases where you are using 5 mm implant in the posteriors also after you do a sinus lift. But there is an option to this 5 mm of bone. We can do denser burrs with the sinus lift. We can avoid direct sinus lift with that thing. Sir, there is a burrs which are used. There are burrs which are being used for indirect, that is closed sinus lift. What you are speaking. There are burrs which can help to reduce.
Burrs are basically
There are burrs. Burrs. They are known as denser burrs. For this closed sinus lift.
Yes.
So where you want to put a 5 mm implant, we can use a 10 mm implant for that purpose also.
I never use 5 mm for sinus.
But you did a 5 mm implant because you avoided a sinus, you wanted a direct sinus
If
lift.
you open a sinus, it's minimum 13, never 5.
But to my sense, why you want to open a sinus if we can do a closed sinus lift?
Price. Because the specialized implants are more expensive, that's all. If the patient wants to, it's okay. I give him all the options. He's choosing, not me.
So his question was that if there is only 5 mm bone available at the sinus region, instead of doing a direct sinus lift, an open sinus lift, why not use a little bit shorter implant like a 10 mm implant and do a closed sinus lift with an osteotome or DEXA burst?
Yeah, but the question itself is wrong. I don't understand the question. If you're doing a sinus lift, anywhere you put 13, either it's open or closed, it doesn't matter. If it's closed, you put 13 always. You don't, if you are, why put less?
Because if the residual bone height is 5 millimeters,
So, okay, so
and you don't want to lift 8 millimeters because when you are doing a closed lift, you are unsure whether you have any perforations in the membrane, etc.
yes, but okay, that depends on you. I would do always 13 or 11.5. Okay. But it's, I don't understand the question. You can do sinus lift, the closed one.
With an
I would not use a
osteogenesis
short
showed
one.
one or two cases where you have fractured the floor.
Yeah, it's okay. You can do that, but I would always advise you to do more than 10.
More than
If it's possible, for immediate loading. If it's not for immediate loading, 10 millimeter is enough. But try to aspire to things that will stay, that you will have, no, exactly, that means the longer it's the better.
Sir, when you are doing single posterior implants, even then are you loading them immediately?
No, no.
Only if
The
they
only
split
place I will
together.
immediately load is front for aesthetic reasons, and I would not give them the chance to eat. In the posterior, I'm always waiting if there are only one or two implants. If it's a complete job, yes. All of them are connected, it's not a problem. But if it's a one or two implants at the back, you wait, I wait. And sinus lift also, I never immediately load in sinus lifting. You don't need to take the implant, anything out.
Any other questions? Sir, these patient-specific implants, the PSIs, the screws here are also titanium.
Yes.
So do they also integrate, or is it more towards a fixation, a stability by fixation?
There are
Have
two
you had
types.
to remove them?
Yes, I try to remove one of them. Sometimes it's very difficult, yes. And you need, sometimes the head breaks and you need to leave the screw inside and to take the implant out without the head of the screw. It can happen. The old ones were machine type. So machine can integrate, but not as strong as the new implants. So now I'm asking them and they are giving me, and if you saw, in some of the cases, the screws have a surface of an implant. So the smaller screws still have a surface of the implant, so they integrate. But it's difficult to take them out afterwards. So I hope just to put them in and to find them in skulls in archaeology with my patients.
And when you are stabilizing the PSI on the lingual, at that time, because a few
The
cases...
lingual what? Nerve
The
or lingual area?
mandible.
Okay.
So at that time, because on the buccal the extensions are quite deep, because you have to go to the
Below
below
the
the
nerve.
nerve.
Yeah.
So do you do the
lingual?
stability?
No. No, because you have the lingual nerve.
Mylohyoid and the lingual nerve.
You don't want to reach below the mylohyoid or the lingual nerve. So everything is above. You've seen it in the video.
So the buccal extension is more and the lingual extension is little bit
You have
shorter.
three connections. The first one is the occlusal one, which is the backwards of the implant. 2 or 3, usually bicortical, which means it goes from the buccal all the way to the lingual. So one big or 3 screws at the buccal area, and usually one at the lingual just for stabilization. But the majority of the power comes from the lower part, the lower implants, the lower screws, that goes from buccal to lingual, from bicortical, 2 cortexes. Thank you very much.
Thank you very much for being such a lovely participant. I hope your expectations from the speakers and the company are fulfilled and most of your queries have been answered. But still, as I already told you, if you have further queries, we already have a group, we'll have you in that group. We'll personally, individually, will send a WhatsApp link to that group to you all individually. Just before dinner, taking 5 minutes to brief you about AV Dental. AV Dental is Israel-based manufacturers. It's a US FDA approved facility. It's a 25-year-old. implant manufacturing facility, and one of its kind in the world who is printing such precise patient-specific implants. So it needs a lot of research, a lot of good technology and precise machine to manufacture such implants. They are one of the pioneers and 25-year-old manufacturing in implants. Unfortunately in India, because of the various price issues, they were not able to enroll. But if we talk about the compatibility, they have all the conical connection, complete range. They have the zygomatic, they have pterygoid now, they have the conical connection, which you can see, ion implants, which are like your tapered connection implants. It's the platform I am talking about. And of course, they have the basic internal hex implant, which is I-55, which comes with double thread for immediate loading solutions, and they have cortical implants as well. So on my left, which is hex implants, just to compare, these are exactly compatible to all the existing Israel systems. To name a few, it's Norris, Eden. So these are compatible, so you will never be required to change your instrumentation or the prosthetic parts. All of them are exactly compatible. And for, of course, the conical one, you would need some drivers if you want to use them. So now all of these implants are available here with Raghav Maheshwari. If he is here, I would like you to introduce. I would like him, you all to introduce. So each and every components, right from the prosthetic components, the availability of sizes are now locally available in your city. So it's good, and I am sure most of you must be already knowing him, but he is here. Raghav, I'd like you to be here. So someone, if you don't have his number, here over the dinner, you can exchange his number, and all the sizes are available with him. And in addition to the implant section, we have our endo section also. So just taking half of your minute. So we have BlueFlex Endo, which is our own rotary file system, quite popular in India. Already it's been 8 years. And we have with us Mr. Pankaj Patel, and he is the exclusive distributor. Pankaj Bhai, if you can please come. Everyone I think already knows Pankaj Bhai here. So for all your endo requirements, he is the person you need to catch. And I would like to thank all my team, Dr. Mayur and the team IDA, Pinak sir especially, to coordinate this. Dr. Jigar, Dr. Akash, thanks a lot. Pankaj Bhai and team, Manish Bhai, Raghav. So thank you so much, and we hope you will invite us again to conduct more and more such lectures. And as a company, we are open to do lectures, and our idea of marketing is education. So you call us, we'll be there for both endo and implants. So we believe in evidence-based marketing. So wherever you are again ready to hear any speaker, we would be glad to be here again. Thank you so much, and I think let's join everyone for the dinner. Dinner is on the other hall. And I think you all need to collect your certificates also. So Raghav will and our team would be there in the hall. So one by one you can get your certificates, and I think the certificates. And anyone, just last 1 minute, let's sit and have a group photograph, because it would be difficult for everyone to come here. So it's better we'll have Dr. Leiser and the IDEA team and Dr. Pinak and everyone sitting here, and we'll have a good group photograph.